Okay, I'm now going to walk through the circle of immunotherapy. Um, so, when looking at immunotherapy, it's one of the treatments where considering just a single aspect is not enough. So, and some people struggle with that concept because many people look to say, okay, what does this drug do? But immunotherapy doesn't work like that. There's a series of gates that need to be unlocked effectively for immunotherapy to work. Um, in standard of care, currently there's only one medicine that's used, one type of medicine called checkpoint inhibitors. Um, However, when you start researching cancer science, um, you you realize that in order to make immunotherapy work for all cancers, you need to treat a lot more things. Um, so we developed this concept called the Circle of Immunotherapy. And what we've done is broken down what the science says into 8 sections. Um, Eight effectively these cheeses that you can see that look like Trivial Pursuit cheeses or bit slices of pizza. And for immunotherapy to work, each one of these aspects needs to be in your favor. Um, for the common cancers that respond to immunotherapy, the first section, train the immune system, is typically in place already. And what this means is the immune system can see the cancer already. And this is typically where there are a high number of mutations in the cancer. And this is typically the cancers where there's been an assault on the DNA of the cells that have got cancer over time. So potentially smoking for lung cancer or skin damage through sun exposure. Um, and these mutations build up over time and create mutations. And some of these mutations become what's known as immunogenic and visible to the immune system. And from studies, the more mutations you've got, the more likely the immune system can see it. The other type of cancer that falls into that category as well are cancers with a mutation that stop working in DNA repair. Um, and these cancers also build up a lot of mutations over time. Um, so for the rest of cancers, uh, this is usually not in place and is probably the main reason why um, the majority of cancers are not relevant for immunotherapy or for checkpoint inhibitors. So this second to last section, checkpoint inhibitors, is what's given in standard of care and considered immunotherapy today. Um, so this building immune memory um, is a new topic that's been investigated and now is going through clinical trials, and is typically what you're seeing dealt with in things like vaccines. And if you follow the clinical trials coming through at the moment, you're seeing strong evidence disease vaccines can make an impact. Um, uh, Typically, the trials are done at very early stage disease. So typically after the cancer is removed from, say, surgery, and then they build a vaccine from the remnants of the surgical specimen and inject it. And what they're seeing in almost every study that's coming out is improved results in terms of um, uh, the number of cases of the cancer coming back are declining sharply. So, for example, in pancreatic cancer, there was a very small trial that was done, and where they were able to measure an immune response from the vaccine, i.e., the vaccine worked, the cancer only came back 25% of the time, in compared with 75% of the time without the vaccine. So there's quite significant changes just from the vaccine alone. Um, um, in later stage disease, just from observational following a patient's doing them, it's typically not enough. And that's largely because these other factors are required as well at the later stages of cancer. Um, That being said, due to the relatively low side effects from training the immune system, for those doing cancer vaccines, the side effects are very, very minimal, typically. Fever is, or some flu-like symptoms, the type of symptoms that most people are used to from any vaccine are typically the sort of side effects people are getting. And for that reason, for people that can get hold of vaccines, um, uh, it makes sense to do it as a logical approach. Um, it makes sense to do it when the tumor burden is as low as possible. And it also makes sense to do it as early as possible because once you've vaccinated the body, that function in the body is there for the rest of your treatment. Many people make a mistake and leave this till right at the end, and then effectively get very little benefit from the vaccine alone, because in a lot of cases, you need the vaccine to be in place to start these other cascades in the circle of immunotherapy to work. So if you're using the book, you'll find this circle of immunotherapy in this patient-led circle of immunotherapy section under hacking immunotherapy, the theory. The theory section lays out what science says needs to be done to get the immune system to work against your cancer. And step one, if you go into it, it will give you then the research of various studies showing the importance of this and how it's reflected in clinical trials. A bit of background on cancer vaccines, and then the types of cancer vaccines. So there's the most advanced one at the moment. It's called neoantigen vaccines, which is very specialized for your specific cancer. So your tumor is taken, analyzed, and compared against your own DNA. And then a vaccine is given only on the mutations in your specific cancer. So everyone getting one of these vaccines, it's a totally unique cancer vaccine for that individual. And there are two types of delivery for this. There's mRNA, which are going through trials, and peptide-based. And the peptide-based, some are going through trials, but they're also available privately. There are many companies in the USA, like the JLF Foundation, doing it. And in Europe, CGAT and NextGen Oncology are offering them. And the prices range from typically around 100,000 in the US to between 30,000 and 80,000 in Europe. And I'm typically given over a year, where someone needs to take an injection between every 2 weeks and every month over a year. And then after around 3 to 4 months, if you pay a small amount extra, you can actually test within the blood to see if the vaccine has worked. So they can actually check to see if your immune cells are responding to the antigens they've injected. All studies are showing them to be effective. There is a cheaper type of vaccine called autologous tumor antigens. It's not as sophisticated. It's effectively where they extract some of the tumor, or they extract some circulating tumor cells, they grow them, and then they break them down just as basically a mush of antigens that are injected into the body. So it's just basically an extract. Sometimes they specifically extract certain antigens from the cancer, but it's the whole protein and injected. The one that's readily used is the RGCC autologous tumor antigens, or otherwise known as ATA, and they cost around $20,000 and are given over a 3-month period. And then there are what's known as single antigen vaccines, and these are where a single protein is targeted. And typically you do this if you, say, were checked for an overexpression of, say, survivin, and then you would receive a survivin vaccine to be focused on that. And early stage studies are showing these to be showing some effect. You can do testing with various companies to work out what antigens are upregulated and which ones may be a good target. And then there's a vaccine available or made in Cuba to focus on EGFR. And then the other type of vaccine are cell-based vaccines. And this is done in a slightly different way, where you extract blood from the patient. for the most advanced clinics, what they'll do is they'll train the immune cells, or extract and train specifically the dendritic cells, to be able to identify certain characteristics of the tumor. What's come out recently is if you train it with both the fragments of RNA or DNA and also protein antigens, the effect appears to be a lot stronger. It's what they call double loading. And Immunocene in Mexico are offering a therapy there. The cost is around 110,000 US dollars. It involves a visit to the clinic in Cancun, 4 weeks of receiving the dendritics, and then that's pretty much your treatment. They are only accepting around 20% of patients, so they're being very selective on who they choose. And we're waiting for the results. I'm still waiting. There are various case studies of some people doing well. It's going through clinical trial as well, but we're yet to hear how effective it is. So that's the kind of gold standard in dendritic. Then there are the majority of dendritics companies only train typically by the antigens, and they have some degree of efficacy with active cancer, not a huge amount, and an encouraging amount of activity in patients who are NED. And then there are TILs. It's an expensive way of extracting tumor infiltrating lymphocytes from the tumor. They're expanded and re-injected into the patient. And then engineered T cells and CAR T. CAR T can have quite difficult side effects currently. It's quite expensive and has not shown to be that effective yet in solid tumors, but some studies are starting to show they're starting to break down those problems, but not yet really achieving the response rates that people are looking for. Intratumoral injections is another way. So Dr. Onik in Florida has invented what is called the in situ vaccine, which involves freezing 1 centimeter of tumor and putting checkpoint inhibitors and a substance called GM-CSF to expand the immune cells by a factor of at least 10. And the idea is to vaccinate a small part of the body and then expand those immune cells in the body in the hope that it can clear the cancer in the body. And he's getting some pretty good success rate. He's getting 40% complete responses in metastatic prostate cancer and some responses in other cancers as well. And finally, the concept of immunogenic cell death. And these are mechanisms of killing the cancer. And while you're killing the cancer, alerting the immune system to the tumor. And in that process, vaccinating the body bit by bit. So this constant process of killing a small amount of tumor in a special way and training the immune system as you go along. Oncolytic viruses are one way of doing that, typically injected into the tumor. And the other way are using off-label drugs, low doses of chemotherapy, and low doses of radiation. There was a quite famous study done on mice where they used ivermectin on triple-negative breast cancer, and it effectively cured all the mice once combined with a checkpoint inhibitor. This has now been followed up in a very late-stage human study. And even though the patients were incredibly and been through a lot of treatments and incredibly late stage, a small number were responding, and one in particular had a quite strong response. So it's starting to kind of indicate that there is potential there for the combination of ivermectin as a vaccination tool. Quite which cancers and how effective it is still needs to be adjudicated, but it's certainly, if you cannot afford vaccines or cannot access them for some reason through clinical trials, then ivermectin may be worth considering. And then there are certain other immunotherapies that all have immunogenic cell death properties, but typically at the lower doses. Once you go above a certain dose, it becomes inflammatory and the immunogenic cell death properties start reducing. And then TKIs as well. There's a certain number of TKIs that have also shown to be immunogenic cell death inducers. This is the study with ivermectin, and it showed this blue line here, basically tumor volume falling to 0. Other modes: hypothermia, cryoablation, HIFU, a number of off-label drugs, and a number of supplements as well. So yeah, if you want to, there's a lot of information there. This is something that we would encourage almost everyone to look at, and consider where they're integrative oncologist, working on building immune memory, because a lot of the approaches are side effect free, relatively low risk, and something that can be done alongside standard of care, and at least help set the body up for an immunotherapy approach when the time is right. So that's the first step. The second step is what we call deplete the tumor's army. Many people may have heard about this through Jay McClellan's book, How to Starve Your Cancer, and many of the online groups. So this is talking about the immune system of the tumor. So not a lot of people are aware that the immune system itself has a tumor that almost replicates the immune system of the body. So Tregs, myeloid-derived suppressor cells, tumor-associated macrophages, tumor-associated fibroblasts, and tumor-associated neutrophils. And if any of these is too strong in the tumor, it will limit the response of immunotherapy. So I'm not going to go through them all in here, but in this section here on step 2, there are science-based approaches to deal with each of these aspects. Now, it might be that you choose to do some or all, or you may want to do some testing with a company like NextGen Oncology or Boston Gene to help establish the magnitude of each of these within your tumor. So there are some good tests now that can help pinpoint which of these is maybe out of favor, and then allows you to focus which drug specifically you need to give attention to at that point in time. The third thing to be in place is something needs to alert the immune system that it needs to come to the tumor. And this is the signaling methods are chemokines and interferon gamma. And basically it's like what we call a beacon to kind of send out a signal to alert the immune system to come to it. Immunogenic cell death does this. So the methods we talked about earlier. Hypothermia, low-dose radiation, and a vitamin A derivative called ATRA. Again, many of these things you can overlap. So you'll notice many tools that you can use cover a number of the segments on the Circle of Immunotherapy. So you can choose, for example, potentially low-dose chemotherapy, and it'll work on a number of those aspects. So the other one is MHC class, and what we're calling uncloaking the cancer's shield. So the tumor has a mechanism to hide itself from the immune system or hide its antigens, and it does it through a mechanism called MHC class, and using a process called HDAC. You can use typically HDAC inhibitors to stop this from happening. So one of the most common ones in studies used is valproic acid, with some very good studies behind it. Dacetatine has some good studies as well. And for those that can access it, you need to be careful with this because it can be quite toxic if used at high doses. Some of the CDK inhibitors as well. For cases with a TP53 mutation, this is basically very commonly locked in place. So it's something you're almost certain you will need to focus on. This has been studied with some solutions, such, for example, as low-dose CDK inhibitors and tinostat, and low doses of methotrexate or oxaliplatin. Okay, the fifth segment, deal with immune suppression. So immune suppression comes in many factors. Um, uh, Histamine signaling. Antihistamines have shown very good results in clinical trials, and it's very difficult to argue why you would not include such a cheap and side effect-free drug. In one study, it improved overall survival from 24 months from 6 months to 24 months. So huge increases in survival. In this one, from 17.8 months to 38 months. So it can be very powerful, this using antihistamines in combination with immunotherapy. TGF beta signaling, quite common in some of like things like pancreatic cancer. You can use things like lorcetan to help focus on this. Pirfenidone. COX is another immune suppressant, which can be downregulated with things like aspirin. And aspirin has shown amazing results. If you can see the blue line here, this was a survival curve with aspirin and checkpoint inhibitors. This was without. The thing to be careful on this one is it can increase the side effects of treatment. So huge increases in outcomes. Definitely lowest doses are recommended from the study, and care needs to be taken if using this approach. But this led to a huge increase in, if you can look at these survival curves, from combining aspirin with checkpoint inhibitors, but caution is required because the side effects were hugely increased when aspirin was used. Adenosine is another one, and things like caffeine has got very good studies. Interesting, there's quite a lot of good studies showing good results of people taking caffeine to eat coffee, for example. IL-6. There's some very good studies with a IL-6 inhibitor called tocilizumab, which not only reduces side effects, but also improves outcomes. And then on the metabolic side, lactic acid is shown to impact outcomes, and DCA can impact this, and also diclofenac. So a huge amount of things you can do. Again, there's so many things in immunotherapy that you can focus on. It can get overwhelming, and there's maybe too many drugs to do them all. So working with your oncologist or your integrative oncologist who works in this space, you ideally want to get to a situation where you're working off testing. But unfortunately for these types of information, you typically need a biopsy. And you don't want to be biopsying too often. So biopsy can give you, if you've got it early stage, it'll give you an indication of where the focus needs to be. You can use something like Perplexity to type in and say, look, for my cancer, what are typically the resistant mechanisms to immunotherapy? And then use Perplexity to help establish which area to focus on. Or you could try the process of rotating, trying a number of things that are highly likely to cause resistance. Try that for a bit and maybe switch to the others over time, because some of these resistance factors are not going to be consistent. So if you address a number at the start and it works, others that you're not addressing may start increasing in resistance and stop the immunotherapy from working. So there's some logic in rotating. The next one is helping the immune cells into the tumor. So one of the easiest ways of doing this is using Avastin. So there's two real things that block the cell flow into the tumor. One is the vasculatory system. So typically VEGF signaling is messed up around the tumor, and you get poor blood flow, poor vasculature into the tumor. And using Avastin can fix that. And then if you look at the studies that combining Avastin with standard of care, again, some huge increases in outcomes. So if you can get hold of Avastin, it's very useful. Again, low doses are generally recommended. And then the more complicated one is the extracellular matrix. And this is often called the stroma, and it's basically the hard shell around the tumor that can protect it. It's been less studied. So if you do find you've got a tumor that's likely to have an extracellular matrix, you're kind of entering a world where there's not been too many studies combined with immunotherapy to focus on this. But some cell line studies and some animal studies are starting to suggest ways of dealing with it. Things like quite closely tied with things like TGF beta. So many of the TGF beta blockers we talked about earlier also work in this space. So things like lorcetan, pirfenidone, membendazole have some evidence for helping to break down the stroma. And then other things that can help are things like hypothermia, low dose radiation, intratumoral immunotherapy, and HIFU. And then we get to checkpoints, and these are the things that your oncologist is giving you. The common ones that are used in the standard of care currently are PD-1 with its ligand PDL1, CTLA-4, and just recently a LAG-3 has been invented that's available in America and starting to be introduced into Europe. These are expensive. They come with high side effects. Many trials are recently starting to suggest that with lower doses, you can get equally effective results and as good and much lower side effects. So if you're able to persuade your oncologist to adjust the dosing, take a look at the immunotherapy practice section. And in here, there's a whole section on immunotherapy dosing. So and then all the studies. So you may want to go in and then have a look and print these off and show them to your oncologist, as it may help get you more checkpoints and reduce the side effects from treatment. Yeah, sorry, low dose immunotherapy, this one, harnessing so this section here has got some really good research on modified doses. There are a number of checkpoints that are not currently available in standard of care. They're going through clinical trial. For these, we've given some off-label drugs that have shown some evidence to affect checkpoint inhibitors. So these are provided in the second section. And then finally, we have something called immune activation and treating T cell exhaustion. So a combination of many of these things, things like the checkpoints, the immune suppression, will basically wear down a battery on the immune cell, what's known as exhaustion on the immune cell. And there are various ways to slow down the exhaustion. And this talks about like L-arginine, interferon alpha, hydrogen gas, mistletoe, propranolol, MitoQ, magnesium, oncolytic viruses. All of these things help give the immune system energy, allowing it to fight the cancer better, and in some cases allowing it to multiply the number of immune cells to increase the power of the attack. So that broadly sums up the circle of immunotherapy. As I say, it's not simple. It does require comprehending quite a number of factions in one treatment modality, and there are not yet many clinics and experts in this space. And we're hoping with this book that people can share it with their oncologists, share it with the people going through the things, starting to read it, starting to discuss these things online, commenting on whether there's any other concepts that we've not considered. So we want to get the patient community and the sort of doctors working in this space community to really start to have these discussions, because we believe from our research that if all these things can be combined, radical shifts in immunotherapy can start happening. One of the things I've not mentioned, for those that maybe don't have immunotherapy as an option for standard of care and are maybe considering it for a clinical trial or in, say, a private clinic, there's one step that it's worth going through to really evaluate whether immunotherapy is right for you. It's what we call knowing when to start and when not to start. So this is step 0. So this gives all the research in terms of aspects that should be in place in order to help make a decision to do immunotherapy. And one of those could be, can I get access to checkpoint inhibitors? Because if you can't, thinking this through in detail, maybe not worth it. Um, the body is not ready. If you've got high inflammation, it's not recommended. If high IL-6, it's not recommended. Neutrophil to lymphocyte ratio, if that's off, also not recommended. High LDH, not recommended. So there are certain things you should consider. There's always a risk of something called hyperprogression as well, which means that the cancer actually gets more aggressive from immunotherapy. You can test for some of these facets. So it's worth understanding that in advance for things like MDM2. So this for those that are maybe considering immunotherapy, this step 0 checking is well worth looking through to say, look, am I in a state to even consider this as an option? And if it isn't, then think about other mechanisms for treating your cancer. But if it is, then look in more detail to where you can get all these 8 steps to improve your responses. So that's it for now. Thank you very much. I hope that was useful.